Hello, I am Prof Cascinu, medical oncologist and director of Comprehensive Cancer Center at the San Raffaele University Hospital in Milan. This is my disclosure. It is my privilege to present a consensus paper from the Gastric Cancer Italian Network about the management of gastric cancer patients. We know that the management of gastric cancer patients remain challenging, and a multidisciplinary approach has long been advocated as crucial in order to obtain the best result. And in spite of several available authoritative guidelines, nevertheless, daily practice is characterized by gray zones, implicated uncertainties as conclusive studies are lacking in several topics. And this Gastric Cancer Italian Network group attempted to establish with the aim of filling the gap between evidence and practice of guiding clinicians in practical management of this disease. And this was done by a multidisciplinary consensus, including different experts, oncologists, surgical oncologists, gastroenterologists, pathologists, nuclear doctors, nutritionists, and the clinical centers were chosen according to their expertise across Italy. We use a Delphi consensus method that in order to obtain opinions from the panel. This is, of course, not a guideline, but this is a consensus among different experts. It's a forecasting framework based on a result of multiple rounds of questionnaires sent to a panel of experts, in fact. And there were 2 preparation meetings, 3 Delphi rounds, and the final consensus conference between May 2019 and March 2020. And we proposed 49 clinical questions identified in 6 areas of interest, going from multidisciplinary team to elderly patient to treatment of locally advanced or metastatic gastric cancer patients. And 3 oncologists and 2 surgical oncologists review the literature in order to answer this clinical question and to propose a draft of statement. And through Delphi rounds, participants were asked to rate their agreement with the statement with a 3-point Likert scale: disagree, abstain, agree. And the consensus was defined when at least higher than 70% of agree, and otherwise with less than 15% of disagree. The statement with a level of agreement less than 70% of agree were rewarded and were clarified. And if no final agreement was reached, those statements were eliminated. And it happened in 8 out of 82 statements. And we propose definitively 74 statements going from the role, again, of multidisciplinary team. We focus on this aspect because, at least in Italy, not in all centers were present multidisciplinary teams. And hereditary gastric cancer, for instance, because in Italy there are several areas where hereditary gastric cancer is present, or PET scan, the use of preoperative staging, and the best approach in this case, the working up of this patient, or multimodal approach to localized gastric cancer. A few examples of this consensus. For instance, in resectable disease, we know that all the patients should receive a perioperative strategy. This means that the patients are candidate to receive a preoperative chemotherapy followed by surgery, and after surgery they have to complete the strategy receiving a post-operative part of chemotherapy. But in Italy, and I suppose not only in Italy, most of the patients nevertheless are candidated to receive upfront surgery. This is not why there is an emergency, but because surgeons continue to think that a surgical approach may be the best for this patient. So they refer the patient to the medical oncologist after a surgical approach. And in this case, we have not clear evidence on what to do. And probably in some cases, we propose to use an fluorouracil oxaliplatin-based regimen because there is some evidence that this may be useful for the patient, mainly for those having a positive lymph nodes. Of course, there is no clear evidence in guideline that this is the best approach, but when we have in front of us a patient already resected, we have to decide what to do. And another aspect important for resectable disease is in the perioperative treatment, not the preoperative part of treatment, but the postoperative part, because we know that most of the patient not recover very well from surgery, and we have to decide if we propose again a combination regimen. We agree that the FLOT in the perioperative treatment strategy may be considered the standard of care, but while it is easy to deliver this regimen in the preoperative part, it's very challenging to offer this opportunity to the patient in the postoperative part. And this means that most of the patients do not receive the postoperative part, or they can receive a doublet, not a triplet. For instance, a combination of fluorouracil oxaliplatin, and in some cases, just fluorouracil. And we tried to identify the patient candidate to receive triplet, monotherapy, or a doublet. And another point that may rise in the resectable disease, but if we know that the tumors have a microsatellite instability, and what we have to do after the resection, because the patient receive the preoperative chemotherapy, undergoing a resection of the disease, but now we have to offer a postoperative part to this patient, or because there is a microsatellite instability, may discontinue the treatment and candidate this patient only to the follow-up. And in this case, we suggest that if the patient do not demonstrate a response to the preoperative part, they are good candidate to receive in some way only a follow-up, but not to continue after surgery the chemotherapy. And there are several questions, even in the advanced disease, in terms of first line. For instance, we have to propose to all the patient a triplet, because in some cases, at least in Italy, several clinicians translated the result of the perioperative strategy to the strategy of therapy of managing this advanced patient. I think that was not completely correct. So we propose that for most of this patient, a good choice could be a doublet and not a triplet, in order to reduce the toxicity and in order to, in some way, have the possibility to design a treatment strategy including first line and second line. And this is why we have in second line effective treatments able to prolong survival. And probably the evidence that randomized trials such as the randomized trial including a comparison of paclitaxel and ramucirumab versus paclitaxel alone show that the combination is able really to prolong survival in this patient, even offering really a good response rate. And response rate may be relevant for the management and the control of symptoms, for instance. And this is why we try to propose in first line a doublet, followed by in second line a combination of paclitaxel and ramucirumab. But otherwise, there could be some patient not candidate to receive paclitaxel because there are neurotoxicity from the previous treatments. So we have to suggest that probably for this patient an opportunity may be irinotecan. And this is why we tried to offer these different opportunities. And we know that the guideline may not offer answers to all these responses because we have these gray zones. So in conclusion, I think that the Green Group elaborated a perspective on the major open question in the management of gastric cancer, and with a great surprise for us, a high rate of agreement has been reached for most statements, suggesting in reality that a shared approach could be defined in most cases, even when conclusive evidence is lacking. Indeed, we believe that our project can be of use to implement the organization in established teams or specialists in Italy involved in the management of gastric cancer patients, and we hope that this consensus may be useful even in other countries, but I think could be really of interest to discuss at this point with other experts from other countries. I would like to thank really for the opportunity to present this consensus paper and for your attention.